morning. I would like to thank you for kind invitation. And without losing the time, I want to start with a case to you. These are the position and job I did up to now. Case is this. This gentleman has 30 years old, had a retroorbital pain and ophthalmoplegia in 2011, and found out a petrocavernous aneurysm on the right side. The first treatment done by the help of telescopic mentality, which actually we found of and created in Istanbul, that Leo-silk combination. As you know, we are one of the first user of flow diverters in the world at those time, and we had a good results to get in that scaffolding technique we described before 2000 by using cover stand. And we thought that this flow diverter mentality is working, especially in that proximal anterior circulation carotid artery aneurysms. And we had a lot of cases for success. That's why the first choice for this case is that one, even though the patient has a good collateral flow. But after a while, in the follow-up period, we realized that aneurysm doesn't want to thrombose. And then we already have in our minds that telescopic mentality, and we got the patient again 1.5 years later than the first treatment, and telescopically put another flow diverter. And then this is also silk. And then in the angio, by doing so, there is still a feeling there, but a month later, we became happy because we had intra-aneurysmal thrombosis that really we want to get. That is our aim. First thrombosis, and then the healing reactions. That is the mentality of flow diverter. But the patient came to me again with a headache. And I checked with MRI and also the angio. What is interesting here, as you realize, a subtemporal region is occupied by onion-shaped structure, and aneurysm is enlarged. Additionally, perianeurysmal temporal parenchymal edema is appeared. Please have a look at this shape. There was no shape before. And don't forget, this aneurysm was infradural. It was not on the dura. This is the angiography. Still some feeling around. This vaso-CT also showing you that the feeling portion is around the neck. But please pay attention. Enlargement pattern is on the periphery of the aneurysm. And this is a 2.5 years later than second treatment. That means the 1 Leo, 2 flow diverter telescopically. Okay? And then she started to have seizure. That seizure was not the presenting symptoms for this case. Even though the collateral flow was there, we decided to give him a chance to get treatment with flow diverter mentality, and we did another flow diverter telescopically. That was pipeline. And after the pipeline, as you realize, one Leo, two silk, one pipeline in the same segment. The edema is gone 2 weeks later. And that new developed portion getting thrombosed, that signals is actually showing that it is a fresh thrombosis. But inhomogeneity in the aneurysm is still there. Please pay attention. Inhomogeneity in the giant aneurysm group. 3rd month later, this is the IV vaso-CT angiography. Still some feeling around the neck, but rest is okay. Let's follow this case. A year later than the 3rd treatment, another year passed. Again, another heart attack. Hey, what's going on here? Look at that. New formations. Again, new edema. Please have a look at the jet flow here. What's going on there? 3 flow diverters, so-called modern flow diverter. We will talk this in this afternoon. What is modern flow diverter, what is not. Actually, flow diversion for me, the misnomer. And then that time that enough is enough. I want to occlude this parent artery, and I did it. I call it. The patient has a nice collateral flow. We already know that from the beginning. That is 2016. 3 months later, again, we had a success to make that part thrombose. Edema is gone. We still have no infarction, no thromboembolic events, guys. This is not a complication of the thromboemboli. This is not a complication of technical things. This is something else. We should take care of this because aneurysms are not mean that small and medium-sized aneurysm. Everyone likes to get a small and medium-sized aneurysm, but the reality is not that. If you don't choose those aneurysms, this is a very, very strong selection bias in your center. You should not put yourself away from those cases. And in the follow-up, a year later than the parent artery occlusion, yeah, still inhomogeneity there that I didn't like. But good enough that the tip of that enlargement point getting darker in T2 weighted images, edema is gone, still has seizure, regularly getting anti-epileptic. This is a 3 year later. Why this aneurysm having inhomogeneities? I have still fear to get additional enlargement, even though parent artery, aneurysm, angiographically occluded. This is a living structure. So when you check the details of theoretical details of vasovasorum, in young adults, actually intracranial arteries are devoid of or demonstrable vasovasorum, especially the pile group, not close to the dura. The vasovasorum mostly found proximal 1 and 2 centimeter of vertebral or internal carotid artery dural vicinities. But when you get the pathology, that means the aneurysm, atheromatosis, vasculitis, or dissections, they are appearing. They are becoming visible. And that laminated onion-shaped organized thrombose in aneurysm, believe that it is a subadventitial rebleeding of these tiny vessels, not because of the feeling from the luminal. that is really important, because in that case, even though I am a big mentor of the hemodynamic treatment all my career, I have a real big doubt in my mind, because this is a perfect failure of flow diverter mentality. Cavernous segment, petrocavernous segment, infradural, simple, so-called simple, young, non-atherosclerosis lesion. Deconstructive treatment or reconstructive treatment at the very beginning? We should ask that question to ourselves. Did we really cure this aneurysm by that story? I have still questions in my mind, because the aneurysm, residual aneurysm mass, inhomogeneous in MRI, and then the wall still has kind of contrast enhancement, which are mostly coming vaso. The body reacts this mass as a kind of living tumor, benign tumor, I believe. So without eliminating those vasorums, that uncertainty is still over there. You may go in details in my book in those type of aneurysm, and I wish to see you all in Istanbul next May in WLNC. Thank you for your attention.
It's time for one question.
Yeah, any questions from the audience?
We have been hearing about this problem of no flow and yet a thrombosed aneurysm enlarging. I mean, we've discussed this at Valdezare over the years many times. Have you used steroids or non-steroid anti-inflammatory drugs in these patients?
At the very beginning, we start the standard therapy, dual, and then we realized that it is not getting thrombosed. We reduced anti-aggregation, but all of them actually, all that 3 treatment period, it is starting 2012 and ending 2016, we didn't cut all of them totally. At least the one anti-aggregation, as far as I remember, in the last year, before parenteral artery treatment. So after parenteral artery treatment, of course, it's all cut.
I was not asking about antiplatelet. Actually, I was asking
I misunderstood you. Sorry.
Anti-inflammatory.
Anti-inflammatory, yes,
yeah.
corticosteroid, because of that all attacks of that aneurysm enlargement, creating edema. In that periods, we gave it.
How long do you give it for? How many weeks or days?
I forgot, but it is a kind of a regular treatment, like we did in tumoral extractions.
Because we had carried out a study, and we have been giving, especially for giant aneurysms, even when there is no flow, steroids for about 2 weeks, and then a patch of non-steroid anti-inflammatory for 2 months. And at least I think that it is effective. Of course, we have not done a study in the sense of analyzing this, but we have a number of patients where it seems to help. Non-steroid anti-inflammatory, either diclofenac, which is what we get as a patch, or paracetamol.
Yeah, that's a good point. But our corticosteroid period is not really 2 weeks, more than 2 weeks, is regular. We will talk about that chronic inflammation, resorbable stents, and then how to manage that inflammation in the afternoon. But you're right. Maybe we need to think on more in those group, not the luminal pitting. There is something going on, chronic inflammation, and also rethrombosis and rebleeding away from the lumen.
Last question, sir.
Just last question. Nachi, thanks for sharing the
great case. And I like the Basavasarum theory, but my question is about the what is the rationale to use high porosity device in a first time, yeah, just like an scaffold, because the anatomy look at really it's not a challenging anatomy, and nowadays you maintain the same rationale to use a high porosity device and then put a flow diverter, because are you consider the fact to put a high porosity device may affect the wall apposition of the flow diverter technology, and probably everything that happened is a consequence of the poor wall apposition?
First thing first, all stent is well opposed. It is all checked immediately after and later in flat panel detector CT angiography. There is no opposition problem in this case. The second, at those years, we haven't got longer flow diverter in our hands. That's why, actually, we already started that scaffolding technique with coronary stent, in it the cover stent. And then we shifted this mentality to Leo-silk combination, and I shift this mentality to the fret. When I first created fret, that mentality fret mentality come from this mentality. And that's why that Leo and silk combination as a first treatment done.